to talk about the projected health and economic consequences of the end of Roe. I'm going to talk about what's known about the impact. And of course, it's all in flux. I'm going to tell you the major findings of a study I led, which was, I did not predict the end of Roe, but it was a study of women who wanted abortions and were denied, which turns out to be extremely relevant to our today. So based on that study called the Turnaway study, I'm going to give you some predictions of the consequences of Dobbs, and then talk a little about the challenges in studying it, so that if you have ideas, you can give them to me, because everyone is madly trying to figure out what's happening, and it's actually really challenging. So if you've been asleep for the last year, Dobbs versus Jackson Women's Health, it was originally a case about a 15-week ban in Mississippi. 15 weeks was well below the thresholds that Roe had set. And so the fact that the Supreme Court was willing to hear it at all indicated that they were willing to overturn Roe. And when you may remember that the decision was leaked ahead of time, which is super interesting, and happy to talk about that. But when they actually released the decision, it was that same leaked decision, and it repealed Roe versus Wade, which ended about 50 years of a federal right to abortion. And so without Roe, then the decision about whether abortion is legal or not goes to the states. And so every state is deciding whether or not to ban abortion. And this is what I have to every time I give a talk, I have to download a new map because things change. But the dark red is they have a full ban on abortion, sometimes for some exceptions. But whenever there's a full ban with exceptions, it's hard to actually get that abortion for the exception. The lighter gray, the lighter colored are bans at certain weeks of gestation that wouldn't have been allowed under Roe. So these are bans that wouldn't be there except for the Dobbs decision. And then there are a whole bunch of states that are on the right hatch marked, and that's because there's some statute in their law, but it's currently being held up by a court. And so they aren't enacted yet, but because I'm trying to study the impact, I'm working with clinics in these states so that if a ban takes effect, that they immediately try and recruit people seeking abortion for our study. So the decision directly affects about a third of US women, a quarter live in the states that have already banned abortion, another 10% live in states that will likely be banned. And what we know is that pre-Dobbs, these residents in these states obtained about 300,000 abortions. So what's going to happen? I doubt that the news of Roe makes everyone stop having sex and demand for abortion plummets. I think there'll still be this similar demand, and what happens to those 300,000 people is the big question. And just to note that there are also, in addition to women, there are an unknown number of pregnancy-capable trans men and non-binary people. So what are the options for someone who has an unwanted pregnancy and lives in a state with a ban? They can travel out of state, they can obtain medication abortion pills, they can attempt to have an abortion without medication abortion pills, and they can carry the pregnancy to term. And I'm going to tell you a little bit more about each of those. Option one is to travel out of state. So more than a quarter of US women now live more than 200 miles from an abortion facility. And we know from how uneven abortion access was in the past that long distances increase the cost of abortion and lower abortion rates. So, and cause delay. So you can actually look at, from a geographic information system, you can look at how far people have to travel and abortion rates in that community. And that's super interesting, and happy to talk about that challenge too, in doing that sort of study. And what we know from these studies is that if someone lives more than 120 miles from an abortion facility, there's a significant decrease in the abortion rate in that community. But abortion clinics don't randomly locate, and so they may be locating in areas where there's a higher demand for abortion. Nevertheless, there's clearly an effective distance where some people aren't able to travel. And there are people that just won't be able to travel. If you're later in pregnancy, you have to go a lot farther. People without money or resources, particularly a car, minors, undocumented immigrants, then there are people who are institutionalized, incarcerated or hospitalized. They can't easily pick up and travel. And other people with mobility issues, like people who are disabled or are undocumented. And yet, despite all those people who maybe couldn't travel, we see that a lot of people are traveling, just an astounding amount of travel that we've seen since that Dobbs decision. On a monthly basis, 9,000 fewer abortions in states with restrictions, but over 6,000 additional abortions in states that don't have restrictions. So 6,000 people a month traveling hundreds of miles to get an abortion out of state. It's a huge amount of travel, and yet you can still, with quick math, see that there's many people who may not be traveling. So option number 2 is medication abortion pills. 2 drugs, mifepristone and misoprostol. They're very effective, and even before the Dobbs decision, about half of abortions obtained through clinics were provided through pills, not through procedures. And they are, in 2021, in response to the pandemic, the FDA loosened regulations about whether a patient had to be there in person to receive the pills. So there are some states that really micromanage that interaction and say it has to be a physician who hands the pills to the woman and she'll then take them at home and swallow them. But no, it has to be a physician who does it. Anyway, the FDA said all of that is not necessary. Scientifically, we can just mail pills out to people. So that opened the possibility of telemedicine for abortion. And there's a group called Aid Access. It's based in the Netherlands originally, that will send you pills no matter where in the United States you live. They won't care what the state law is. So if you go to Aid Access with a sliding scale, they'll mail you pills. Originally, they would only send you pills from India, which took a long time. If you lived in a banned state, now they'll send it directly. So Aid Access is one way of telemedicine, and there's an actual clinician looking at asking you some of the risk factors. There are also, with no medical attention at all, you can go to an online pharmacy and order pills. This existed pre-Dobbs, and somebody in 2018 ordered 60 sets of medication abortion pills from 60 sites, and then tested the medications and found they were all actually the drug that they were supposed to be, which is a miracle. And I don't know if that miracle is still happening. Some of the packages had been tampered with so they wouldn't rattle. And that meant that some of the pills were a little degraded, but probably not enough to affect efficacy. And then there's a community group called Las Libres that's Mexican that will send you pills. So there's really quite an infrastructure to get people pills. There's some trick where you make the bar at the bottom go away. Does anyone know what I push so I don't have to see unmute?
Go to more and then high floating mean controls.
Okay. Thank you. In any case, so when my previous slide that showed 9,000, thank you, 9,000 pills, 9,000 people traveling, 9,000 fewer abortions and 6,000 people traveling, that included some telemedicine. So that included Aid Access, but here is, so the barriers, who's unable to access this, you have to know about it. And there are some amazing websites, plancpills.org, ineedana.org.com, and those will, you put in your zip code and they'll tell you where's the nearest clinic, what funds would help you get there. Here's how you can order pills online. It's really astounding what the information that is available, but you have to know to go to these sites. So in order to do this, you need a computer, a smartphone, a credit card, debit card. Some of them are free, but then you have to testify that you need it for free, and you need a mailing address. And so all of those can be a challenge for certain people. Most states that ban abortion also ban telemedicine, but we're not really talking about people adhering to the law very tightly with this. And pills can be slow to arrive. They can theoretically be intercepted, although we haven't heard that that's happening. And biggest problem is that taking medication abortion pills isn't very fun, and you can have bleeding, and you can need to take additional pills of misoprostol to complete your abortion, and you may need some guidance about, and the risk is that if you don't have any guidance, you would show up in an emergency room and the people there might turn you in. And if you didn't admit that you had taken any pills, they would never be able to tell the difference between a medication abortion pill abortion and a miscarriage, but people may not know to not disclose. So there's all sorts of legal potential, and there is a whole website called MA Hotline, Medication Abortion Hotline is what it stands for, where clinicians will advise you if you're experiencing symptoms, whether to get emergency medical care or just take more doses of misoprostol. And there's also concern of legal risks. So there's a whole website that also sets up in case you need legal help. So really the amount of energy to help people circumvent these laws is really tremendous. So there we have the physicians and the legal teams helping.
Is there a universe of kind of anti-abortion websites that you stumble upon when you try to go to all these websites?
If there isn't, there will be soon. Or fake mail order would be really great if you wanted to disrupt this, you know, to say you're going to send someone medication abortion pills, but send them something else instead. In 2018, that didn't exist. Does it exist now? I don't know. But there are people who are ordering and testing, so we will know. So this is the New York Times's estimates of how much it costs and how long it takes if you order from like a pharmacy website versus Aid Access versus Las Libres in terms of how much it costs. You see it's free from Las Libres, but it takes the longest amount, or takes 10 days to arrive. Aid Access, you'll get more medical attention, but it will take the most time. And then online sellers are most expensive and quickest. So people are so somebody tested all of this, and the most expensive arrives the quickest, the least regulated arrives the quickest. So despite those barriers, we also think from the New York Times that a lot of pills are being sent. So Aid Access, in just the 6 months after the Dobbs decision, there was an estimate that about 50,000 sets of medication abortion pills were dispensed. And that's more than the gap you might have seen in between travel and what abortions it used to be. But note that not all of these pill packs are new. The pill pack sending by mail has existed even before the FDA gave its blessing. And Aid Access, for example, served just under half this amount before Dobbs. So it's not all new sending. And more than that, so there's, if you just look at 6 months post Dobbs, 35,000 fewer formal sector abortions, 50,000 pills sent either informal sector or through Aid Access. And so in case you think, oh, well, not all, you know, we've more than made up for any gaps. In fact, we don't actually know what true demand is, because the pre-Dobbs era counts Texas, and Texas had a 6-week ban. So already then the number of abortions was less than it probably demand would have been. 50,000 isn't a total increase. Many people got these informal sector abortion pills before Dobbs. Some people might be ordering for advanced use, so they may not all represent abortions. Demand for abortion may be increasing. In fact, the trends do show that abortion rates have been increasing. So the idea that if we just hit the number of April 2022, that's all demand, well, it may not be if the need for abortion has been increasing. And then also, importantly, not everyone could get a formal sector abortion. Even under Roe, there was lots of unmet need for abortion. A lot of people, I did a whole study that rested on the fact that some people want abortions and can't get them. So the pre-Dobbs count isn't necessarily a full count of abortion need. So I was asked by journalists, like, how many people won't be able to get their abortion under Dobbs? And I just want to justify my estimate. there were many studies that show that when there are financial barriers to abortion, a quarter of people can't get them. And it was like multiple different contexts, different states, Medicaid funding was dropped for abortion, how many more births, and they all came out with about a quarter of people who want an abortion won't be able to get one. And then there were studies of geographic access. So if you close down a clinic, what happens to abortion rates when people have to travel insane distances? Well, a quarter. So that's what I said, like every reporter is like, I don't really know, but I think about a quarter of people won't be able to get their abortion. And now it's, maybe that wasn't quite the right estimate because maybe travel and money aren't the barriers. Maybe people, when you get pills that were free from Las Libres delivered to your house, maybe the financial and travel is not the main consideration in whether you're able to get an abortion. And right now, maybe the major barriers are legal barriers, being afraid of getting prosecuted for having an abortion, not having information about how to get those pills from Las Libres, and stigma. So it turns out 25% is high. What I'm seeing is 5 to 10% maybe are not getting their abortions.
That's 5 to 10% of the people in the affected states?
5 to 10% of the people who would have been able to get an abortion pre-Roe are not able to, is my estimate. And that's very, still, I should hedge like I should have hedged on the 25% because we don't know, and we'll know more when birth rates come out, when birth rate data are available for these states.
It's 5 to 10% of the states where it's banned.
It's not that the birth rate will go up by 5 to 10%, but 5 to 10% of people who otherwise would have been able to get an abortion are instead possibly going to carry that pregnancy to term. And I think 10% is high. And so it's super interesting, like what happens if the impact isn't horrendous, then what will happen to all the vast resources that are required to get all those people abortions, to travel, to get pills? Like what will happen to the infrastructure that's set up to circumvent the law when people are actually successful at circumventing the law? I don't know whether the amount of effort that's put in now is sustainable. So here's, this is the most grim possibility, is that people will try and give an abortion to themselves without using medication. This happened pre-Roe for sure. And it's not actually totally uncommon now. We did a study using that big panel data that I'm blanking on, and asked people if they'd ever tried to end a pregnancy on their own, and 7% lifetime estimate of trying to end a pregnancy on their own. A quarter were successful, and this is in order of what they tried: herbs, misoprostol, and mifepristone, so that's probably super effective. Other drugs, so this is like drinking a ton or taking some other drug, and then physical methods like hitting themselves in the stomach. And 11% report that complications needing treatment from whatever they tried to do. So the last possibility is that they carry their pregnancy to term. And I led a huge collaborative effort, mostly at UCSF, but with scientists from UC Berkeley. Jane Walden worked with me, and many other universities and institutes, to look at the mental health, physical health, and socioeconomic consequences of getting an abortion versus carrying an unwanted pregnancy to term. So I'm just going to quickly give you the findings and not the full analysis of this study. But briefly, what we did was we recruited 3 types of women over a 3-year period, people who showed up at a clinic just a little bit under the gestational limit of that clinic, and just above and were denied, call them turnaways, just below and got an abortion, and we call those near limits. And that comparison between turnaways and near limits is the scientifically relevant one to talking about what's the impact of being able to access abortion on your health and well-being. And then, because most of these facilities had limits in the 2nd trimester, but 90% of people who get abortions do so in the 1st trimester, we also had a 1st trimester sample. Because at the onset, I was a little worried if we recruit people way up near the gestational limit of places that have gestational limits in the 2nd trimester, maybe their lives will be a mess and their lives won't turn out what they expected or something. And so we won't see the true effect of getting an abortion because we've limited it to a sample of people who are disadvantaged, was my thinking, but I turned out to be wrong because there actually were very few differences between the people who sought abortions early and later. So we ended up interviewing about 1,000 people over a very long time period, calling them every 6 months for interviews in English and Spanish. We did it all by telephone. And these are our recruitment sites. So sometimes you'll say, oh, have you been to whatever state? And I'm like, yeah, I've been to the clinic in that state. So I've had quite a tour. So the big question, the reason we did this study was mental health. The idea that abortion hurts women was a motivation for restricting it or for instituting time limits. So people should think more carefully about having an abortion because otherwise they would be depressed, was what our Supreme Court Justice Kennedy thought. And so this was, and do you remember when the Bay Bridge had a big billboard that said abortion hurts women? It was the slogan for the anti-abortion movement because they wanted to be feminists, they care about women. And so if abortion hurts women, that was their slogan. So the big question was, what was the mental health consequences? And this is summarizing a whole bunch of papers very quickly, but I will give you the bibliography so you can check it out. But what we find is that actually the harm from abortion comes from denial. We see elevated depression, elevated anxiety, lower self-esteem in the short run among the people who are denied an abortion. But over time, the mental health of the people who got abortions and the people who didn't get abortions were actually the same. So there wasn't mental health harm from abortion, but there also wasn't mental health harm from denial of abortion. And not because both groups are doing so miserably, one suffering from an abortion, the other one with a kid they can't take care of. In fact, both groups did well over time. Both groups improved their mental health over time. And so here's just a graph of depression symptoms over time between the near limits and the Turnaway births. And here's anxiety, where you see it's actually statistically significant, very short-term elevated anxiety for people denied. So, but being depressed is one thing and having regrets or being sad is a totally different thing. So just looking at the emotional experiences. So more than 95% of the people who got the abortion said it was the right decision for them. And that's the most famous statistic from the whole study. And this is consistent with, this is just among people who got abortions. So these data have been, it doesn't take that special comparison group. You can just study people who had abortions. It's a little tricky to recruit them because people who decades later admit to their abortions turn out to be different than the people who get abortions in a way that resulted in that spurious breast cancer link. But in any case, this has been replicated with other studies that positive emotions, especially relief, are more common than negative emotions, but negative emotions are also common. About 4 in 10 women have some negative emotions about it 1 week later. But even among people who say they have negative emotions, 90% say it was the right decision. So you can be sad, but it doesn't mean you feel like you made the wrong decision. And also, most people who are denied the abortion say that they're glad they were denied. So emotionally, people are resilient to abortion and to getting a child that they weren't initially ready for. And 12% said they still want an abortion after the child was born. And who particularly is likely to say they still wish they could have had the abortion are people who place for adoption, because placing for adoption is very hard. Very few people choose to place for adoption, but the experience is hard. So here's just negative, how much we asked them about 6 emotions, and we asked them how much they felt these emotions, and then we categorized them. Did they feel primarily positive emotions, negative emotions, or they said, I'm not feeling any of these emotions, or and what you can see is positive emotions in blue decrease over time, negative emotions in gold for Cal, blue and gold, decrease over time. And what expands over time is people who say that they're not thinking about it anymore. And one person said to us, the only time I think about this is when you call for these interviews. So, but just because there aren't mental health and differences doesn't mean there aren't physical health differences. And here there are large differences. I'm in an OBGYN department, and this is technical language, but continuing a pregnancy and delivering a child is a really big deal. It's so unappreciated by most people, the physiological stress. There were beautiful articles when the Dobbs decision happens about just the callousness of suggesting that people just deliver and place a child for adoption as if delivering is the simplest thing. And what we find is consistent with the medical literature. Women are much more likely to have a life-threatening complication from birth than they are from abortion. And it's not just the moment of delivery or even the year after, it's for years later, women rate their health as worse if they delivered than if they got the abortion. Oh, I thought there was a question. So what we see in particular is more hypertension, more joint pain, more back pain, migraines, headaches, and just overall poor health. And then 2 women died of pregnancy causes who were denied abortions, which is an astronomical death rate. And if you're sneezing on Zoom, then could you mute yourself? So this is just a graph of physical health. You can see that people who are delivered statistically more likely to say that they have poor or fair health as opposed to good or very good. And in this analysis that Josh's class is going to rip apart in a few weeks is divides it by trimester rather than study group. So if you're in that class, that's a weakness of the paper, is that we really wanted, there's a lot of talk about second trimester versus first trimester abortion, so we divided it differently in this paper. This is incidence of chronic conditions, and gestational hypertension is higher for the people who delivered, and it's not just that pregnancy. People had a lot of pregnancy in the subsequent years. So there was a lot of pregnancies. People became pregnant again and sometimes opted to keep that next pregnancy if they'd received an abortion. So there were lots of pregnancies in both groups. And here's just the 3 chronic pains that were higher among the people who delivered than the people who received an abortion. So other life outcomes, and I'm not going to do justice to these, but if we compare women who received an abortion, compared to women who received an abortion, those who were denied, more likely to live below the federal poverty level, more likely to report they can't afford food, housing, and transportation. I was contacted by an economics professor at University of Michigan who suggested we link the people in the study to credit reports, which is brilliant because it's this objective measure of financial health. And so Sarah Miller at Michigan linked the people in the study to credit records, and you can see greater chance of eviction, bankruptcy, larger amounts of debt for the people who were denied abortions than people who received abortions. And then we asked a lot about their existing children, because often a reason people give for wanting an abortion is to take care of kids they already have. So we asked about economic support for those children and developmental milestones. And you see they're less able to provide with their existing kids. And then we asked them if they were trying to become pregnant, and then if they did become pregnant, a retrospective measure on intentions also. And we see that women who are denied an abortion are less likely to have an intended pregnancy. This is something that is often not considered, this idea that, oh, you should carry this pregnancy to term, and it can be at the cost of having another child later under better circumstances. And maybe that's because people have all the kids they want once they have to carry a pregnancy to term they weren't ready for, but it's also because those better conditions don't emerge. They have less economic security and worse romantic relationships. So equally likely to be in a romantic relationship with the man involved in the pregnancy, but less likely to be in what they call a very good, high quality romantic relationship with anybody. And then we asked them at the end of each interview what their plans were for the coming year, and we categorized their plans into aspirational, neutral, or negative, and people who knew they were going to get their abortion. We didn't have a true baseline where they didn't know yet whether they were going to get an abortion. That would have been amazing, but it's not feasible. But they were less likely to set aspirational plans if they knew they were being denied. And we can also see that they're less likely to achieve aspirational plans. So here's some data on self-reported household below the federal poverty level. It loses significance around year 4, but this is the financial distress data from Sarah Miller and Laura Wary. where they could, the amazing thing with credit reports is they're archived, so you can look for years before they even became pregnant and then years after. So you see that in fact, the two study groups were very similar before the dashed line year of the pregnancy, and they diverge and don't converge again over the next 5 years. So these are things like low credit score, a lot of debt, evictions. Yeah, this won over economists much more than my self-reported economic well-being. And this is just the London measure of unplanned pregnancy, goes from 0 to 12, where 12 is more intended and 0 is less intended. And you can see these are, the green is the index pregnancies, keep towards unintended, and the blue, dark blue, is a subsequent pregnancy for women who got the abortion. So they're not all intended, but there's a much wider range, and including some that were well into the intended range. So concluding the Turnaway study, but not this talk. So the Turnaway study was able to look at how abortion services affect people's physical health, well-being of their family, and trajectory of their lives. And we see better physical health, financial security, setting of aspirational plans, ability to take care of existing and future kids for those who are able to get an abortion when they want one. And just to say, we asked people at the very beginning why they wanted to have an abortion, and they pretty much, we could have just stopped then, because they pretty much just told us all of our results. They knew exactly what would happen to them if they couldn't get an abortion. Their reasons are pretty much our findings. So it's not to say we shouldn't have done the study, because people don't necessarily believe them, but the reasons people give are very, our results aren't surprising because they mirror what people say they're considering when they're trying to make this decision. They're like able to look at their circumstances and predict what would happen to them. And so in lay language, pregnant people can make decisions that are right for themselves and their families. And as we take their options away, their lives will become harder. So just a plug for a book, but more importantly for this crowd is the top is our annotated bibliography, like 52 maybe papers, not all done by me, but by a huge group of scientists from across the country working with these data. And then I did write a book. It came out in like the one time in American history when we weren't talking about abortion, we were talking about racial justice and COVID. So that was a little odd on the time it came out in 2020, but it's unfortunately having a resurgence, which I'm very sorry for. But what's nice about the book is that it has the stories in their own words from 10 women from the study telling how they became pregnant, how they made the decision, what happened to them when they were turned away. And they're amazing. And I am not a qualitative scientist, and I was like, let's go through all the open-ended responses in our survey and find the people who give the juiciest open-ended response, who are really generous with their responses. And I said that out loud, and some qualitative people were like, no, you can't do that. Why don't you just start with a random sample, and then when you can see if you need to add certain experiences. So that turned out to be wise. And we did oversample people who placed for adoption because they're rare enough that you have to oversample, but otherwise the stories were from people who were randomly selected. We never had to go back and get people who were willing to talk, or who had interesting things to say. So I recommend the stories. So what does this study tell us about the consequences of Dobbs?
Get into it about 10 minutes to 1.
So for questions, I'm going to zip through at top speed. Is that okay?
That's totally fine.
10 minutes until...
We should start taking questions about in the next couple of minutes.
Okay, good. So wealthy people will still be able to get abortions, but not disadvantaged people. People who are pregnant and don't want to be will face very serious physical health risks, and I'm worried about self-harm, and I don't know why we haven't seen reports of that yet, but I can't believe it's not happening. And there will be people who are forced to carry a pregnancy and who will die because we have very high maternal mortality rates in this country. And it won't just be then, it will be for the rest of their lives. There will be worse physical health. Amy Coney Barrett was really sure that people would just place their kids for adoption, and we know from the Turnaway study that's extremely unlikely to happen. Most people choose to parent, and more unwanted births now means fewer unwanted births later. and economic hardships and some curtailed life ambitions for people who can't get an abortion. Look how I zoom through. More children will be raised in poverty. And what we see is that children born from the unwanted pregnancy do worse than the next child born to someone who was able to get an abortion in terms of poverty, and the mom reporting poor emotional bonding, maternal bonding. And then also existing children do worse. So often women say, I want to take care of the kids I already have. We see lower achievement of developmental milestones and more living in poverty for existing children. And people understand their circumstances, and when they, the effect of denying people access to abortion will deepen existing health disparities and economic inequality. So I'm trying to study the end of Roe with my colleague, Nancy Berglass. So I had the idea it would be the last person served in their state before a ban took effect, and then people whose appointments had to be canceled. And I had it set up with a whole bunch of clinics that the minute they had to shut down, they would issue these invitations via text and email. And I had enough time to get a lot of scientists to put their input on what we should ask them, and it was all going to be electronic surveys. So we were ready, but bans took a lot longer to implement than I expected. The idea is to study who travels, who self-manages, who carries the pregnancy to term, who's getting what assistance and what makes a difference in enabling people to get care, and then what are the health, economic, and legal consequences. So we've recruited from 17 states, and we're waiting on states that haven't implemented their bans, but I only got about 250 people that way. I think text invitations to participate in the study maybe they're not as good as when we did it by phone. So now we're trying to recruit through call centers and hotlines, places you could call if you needed help traveling, to see with help who's able to actually get there and who isn't, and what do they do if they aren't. And we have 200, but it's increasing every day, people who are calling hotlines from banned states who are entering our study. So it's not easy to time the implementation of these bans. Recruiting via text and email is the pits. Retention is a challenge when you never have any human contact with somebody. And I want identifying information because I want to do that link like Sarah Miller did to various educational databases and income databases. But when you're asking people about illegal behavior and then ask them for their social security number, it's tricky. And I have resubmitted, it's my second submission on an R01 to try and get federal funding for this.
Floor's open. Raise your hand.
Ron.
Well, wonderful talk, and learned a couple of pages of writing as fast as I could. But I'm wondering what the anti-abortion folks make. I assume they've picked up on the high proportion of those who were denied, who then subsequently said they were glad they denied. And I would be interested to hear more about that, and wonder if in newer work there's more probing of that, and if there's any association of those positive attitudes with the socioeconomic impacts that you described, which seem so very adverse.
I think asking people if they regret their decision is super important for the abortion group, because there's this myth that people regret and are depressed. And I haven't heard a lot of arguments you should deny people abortions because they won't regret having a baby. So we asked it to be parallel, but I think only one of them has been an argument against abortion rights or for abortion rights, which is that women regret their abortions. That isn't true. I think that asking people if they like the way their life turned out isn't perfect. People want to say their life turned out for the best. And we can see with other objective measures that their life would have been better off if they hadn't if they had been able to get an abortion. So yes, the anti-abortion people have noticed that one finding, and they never report in the same breath that the people who got abortions are happier that they got their abortion than these people are that they were denied. That they don't do both. They usually just criticize the study, and then if they don't criticize the study, they just hold that one statistic out. They've noticed, but they're right. We were like really dedicated to publishing everything and not just from one political side. And the fact that it seems like a big abortion rights talk is because that's actually what the data show. You know, we didn't, and I find strength from the fact that the women were able to predict all our outcomes, that we're picking up the experiences of people's lives. You know, these aren't spurious findings. These are what people are considering when they're making the decision, and it pans out. But we were committed to publishing it all, and that includes that statistic that people don't say when they're holding their baby, man, I wish I could have had an abortion. And the people who do say that are the ones who place for adoption are more likely to feel free to say that.
I mean, it would be terribly hard to say you were sorry you were denied the abortion when you have a child.
Social acceptability.
Denying the child.
There's social acceptability, but we also measure, there's a validated scale of maternal bonding, and we gave that to everyone for every birth, for every kid under 18 months. And you can see that the women who are denied abortions are less likely to have worse maternal bonding, the child born from that pregnancy, than the women who got an abortion and went on to have other kids later. So they may be glad because they're holding this baby because they are doing their best, and they really are doing their best. Most don't hit levels of poor maternal bonding, they just have worse scores. But I think there's, you know, it's not I guess that one statistic doesn't summarize the entire experience. Just like some people, 40% of people have negative emotions, but they still say it was the right decision. You know, there's whether it's the right decision is not the full measure of the experience.
Yeah, please raise your hands quickly so I don't only see one hand. Raise your hand now if you have
a question about the sampling in the Turnaway study. So you must have had some people who refused to answer.
Yes.
Were the proportion the same for the women who got the abortion than the women who did not? And
yes.
Do you think that could bias your study in some way?
So that's the main critique that the antis like, is that 37% of people agreed to participate, which for a longitudinal study on any topic is normal. It's not high or low, but yeah, there's a concern that if you're, you know, super stressed about needing an abortion, you're not going to want to talk about it every 6 months for 5 years. And I've done what I can to look at whether the emotional experiences of the people in the study are similar to other studies. And I don't see how that selection of participation could be biasing any of the economic or health outcomes. So you could say maybe we're too cheery about emotions towards abortion because they're having to opt into the study, but I don't think it's a valid criticism of most of the other outcomes, like whether a kid hits developmental milestones.
And the proportion were
it's the same. Yeah. It was a little higher in the first trimester sample maybe, but.
Question cluster right here in the middle of the right side of the table. Paul,
because the only ones who could hear me.
Well, thank you very much for your very interesting talk. Especially as a non-American, I learned a lot about what's going on. I had, of course, some idea. I didn't know that it was that bad. One of the things that struck me is that it seemed that you were comparing every time like women who didn't want to have children and then opted either for abortion versus those who had to complete the pregnancy due to law or because they didn't have the means to. But there, of course, also can be negative economic and health consequences for women who have children who actually intended to have the children. Have you also compared those with each other? Because in certain ways, I think the results will be even stronger if you can show that not wanting to have the child and to have it is worse than wanting to have it have
Yeah.
it and have it.
No surprise that kids are expensive. First, just a correction. Everyone in the study was denied because they were too far along. And so the main comparison is people who were a little bit too late to people who were just under the limit and not economic means. So we don't have that selection problem at the onset. And since the limit varied tremendously by site, there were people who received and were denied abortions at the exact same gestation. They just went to different clinics in different places. So it's not, so everyone was denied for advanced gestation, not for economics. And so everyone wanted their abortion. Some people got it and some people didn't. And it was an accident of what clinic you went to and weeks. So that was one correction. And then the question was, did we compare to kids, to subsequent kids? So there was a potential to, we had kids born to these same women after they'd gotten an abortion and opted to deliver. So theoretically, the economic hit from those people, from the subsequent pregnancies compared to the index pregnancies is sort of what is the comparison that we're able to make. So one is I was denied an abortion, so I had this baby, and then versus I got the abortion and I, within the 5-year study period, had a baby. So those are more the like intended births that you were looking for.
Right, but I thought that you wanted that intended birth from women who never had the idea of having
Abortion,
an
so they're not
abortion.
in this study.
They're not in the data. but
Everyone
you-
entered this study because they wanted an abortion.
Right.
But if I did like have the people who planned their pregnancies perfectly, never had a pregnancy scare, always, planned it to the month when they wanted to conceive, I would be introducing other selection problems. So it is kind of nice that this sample is all people who are in the same circumstances at the same time.
Okay, we're at the end of our hour, but let's take one last question here, and then please feel free to talk to afterwards.
Yeah, my question is about the data that you presented at the beginning. You said that if a woman is greater than 120 miles, that's associated with a decrease of 68% likelihood of accident. So that's not surprising.
Right.
What I'd like to know is so the more rural the woman is, the less likely she's going to be able to access an abortion. So do you know what approaches are working to reach rural women in the states with bans?
I sure wish I did know, and would love help in figuring out how to reach them. Because if they never make it to a clinic, then my design for the end of row study of last served in their state and first denied in their state doesn't ever include them. So it's a super challenging problem. And it's not just rural people, but lots of people aren't able to access abortions. And how do you, if they never make it to a clinic, how do you get them? This is a challenge, but I don't have a great answer. I mean, I guess I've been surprised at internet access, how many people have it. And so theoretically they can order pills online and have them sent. And I don't know how the word is getting out to people, but the quantity of pills being sent is vast. So the word is getting out somehow.
I think everybody turns to the internet now if they have a question.
Yeah. And so Josh is concerned that there would be fake sites that give you misinformation. It's a serious one.
Okay, thank you so much. Great. I'm sorry we didn't get